Good morning, everybody, and welcome. My name is James Simoes, and this is an ongoing news discussion on behalf of Protect Our Care New Hampshire. And today we've got some big news that we're looking at, and today we are looking at the North Country of New Hampshire, which is particularly impacted by what we heard yesterday. Yesterday, we know that the US Senate passed the so-called Big Beautiful Bill by just a single vote. And today, it heads to the House of Representatives for debate, with historic cuts to Medicaid and the Affordable Care Act hanging in the balance. If enacted, this budget would have lasting consequences in New Hampshire's North Country, where thousands of residents depend on the Affordable Care Act subsidies and tax credits, as well as Medicaid expansion to have access to healthcare. And for rural hospitals, assisted living communities, nursing homes, and veteran services already on uncertain footing, these programs are a financial lifeline. So today we're going to hear from three North Country residents, a healthcare leader, a nursing home administrator, and a small business owner to explore what this means for their communities and where we're going to go from here, excuse me. Our guests today are Ed Shanshala from Ammonoosuc Community Health Services, where he is the CEO, Raymond Bauer, who is the administrator of Riverside Rest Home, and Bob Tortorice, who is the owner of Building Alternatives in Franconia. Gentlemen, thank you for joining us. I'm just going to start with a general question. We'll do this. Whoever has an answer, just jump in. This is a conversation. So what's happening now with what we heard yesterday with Medicaid and funding on both the state level and the federal level? What do you see? What do you hear? What's your reaction to the news? Why don't we start with Ed, because you're on the healthcare side.
Yeah, when I think about that macro level, and I do think about our patients in primary care, and also think about our critical access hospitals, the whole continuum of care. 500 of our patients we see self-identify as veterans, as an example, and as our patients age, some of them will spend some time in nursing homes, either for rehabilitation services or for residential care. So when I look at the state level, the work requirement gives me some concern. As a fiscal conservative, it's not really clear that the money we invest will find people who are maybe less than honest in their accessing Medicaid. The 3% that was going to be cut was restored, so that's kind of a bright little light in the state of New Hampshire. And at the federal level, it was only one vote, yet the Senate bill is more severely impactful to the Medicaid than in the House, as we'll have to wait and see. For us, it's a $500,000 adverse impact. That's significant. But what I've noticed, and this is why I really wanted to hear from Raymond, is we're not hearing a lot in the popular press about the impact on the continuum of care from assisted living to nursing home. There's some impact potentially on hospice and palliative care. And then spending time with Bob Tortorice, who's been on my board of directors in the past as a retired veteran Navy Seabee, as well as a business owner. 1 in 10 veterans are on Medicaid. So I thought that he would have some sense of his direct experience working with veterans of, what does that mean if they can't get Medicaid? What does it mean if a hospital closes? Where do they get care now? So that's that 30,000-foot level, and I thought it was important to think about those facets of healthcare that I just haven't seen anybody discussing in any depth.
Yeah, I'll take a shot at the nursing home piece. So I've been a nursing home administrator for here at Riverside for 38 years. And this is certainly the most stressful time in terms of funding in the short term, but particularly as the U.S. government struggles through their decisions regarding Medicare and Medicaid. They talk about cuts, but it's not definitive exactly where these cuts are going to come from. And it kind of leaves us all standing on pins and needles. Right now, New Hampshire is what we call a 50% state, meaning 50% of the cost of Medicaid is paid for by the feds. And in cases of nursing homes, or Choices for Independence, which is a home care that qualifies for nursing homes, but people can be cared for at home. They medically qualify for nursing homes. The situation there um, is if the feds cut back in those areas, I think our state particularly is ill-equipped to make up the difference. And as is just shown by this last legislative session, where they passed a 3% increase in the county share of the non-federal share, which basically the counties pick up 98 or 99% of the non-federal share, and the state picks up a very small portion of the non-federal share in comparison. So there's just a lot of uncertainty in our area. Um, and again, I think we're in a state that's ill-equipped to manage any costs that are passed down to them. And as a 50% state, uh, we pay the highest amount of a non-federal share. Other states, like one that comes to mind is Alabama. The feds pay 83% of Medicaid, and the state of Alabama pays 17% because New Hampshire is considered a rich state. I think there's a lot of people that live in my county that would uh, not feel that way, or would be surprised that they're so classified. But so those are the uncertainties that are being faced in the nursing home Medicaid portion, of which, as an example, I'm 100% Medicaid. I might have a few people as they enter the facility who have a small amount of money and they spend down to the Medicaid eligibility. Uh, but primarily, I have no and do not seek any private pay customers uh, because there's a balance in nursing home care. And the balance is the private and the not-for-profit nursing homes um, need those private pay people to balance the Medicaid payment, which, as we all know, is not anywhere near adequate, uh, just like it is in every other service that Medicaid covers. So we choose to support our the private nursing homes and the not-for-profit nursing homes in our area by taking all Medicaid so that we're not taking any of their private pay opportunities away from them.
Very collaborative, fiscally responsible, and probably information that our viewers, unless they've had people in nursing homes, would be less aware of.
And I think even if people are in nursing homes, they're not aware of that piece.
Right.
You know, they're aware of how to help their own loved ones or the person themselves, the resident themselves, if they're competent, how to qualify for Medicaid, which is a tremendously complicated process, and a process that the state is very far behind in qualifying people, which is another problem because, as you know, part of the federal recommendations right now, I guess I'd call it, is that there's only a 30-day look back.
Right.
So if you apply for Medicaid, there was a 90-day look back, and that was hard enough to comply with when the state's taking, months and months to qualify someone. You're basically not going to get compensated for that period of time. And so there is some money in this budget, though. I do give the Senate credit. They did put some money in this budget for the state to hire outside contractors to help people go through the Medicaid process quicker. So hopefully that'll help offset that 30-day
Right.
look back window.
So if we pivot to veterans, Bob, and think about the 1 in 10 who are on Medicaid, and I don't think that's generally known. In fact, until recently, I was honestly less aware of that as well. What concerns do you have as a retired veteran is when we look at Medicaid specifically, but Medicare has at least been talked about. And the Veterans Administration has been talked about as far as a potential reduction in investment. So what are your thoughts on the impact on veterans?
Well, basically, part of what I find about the veterans is they don't trust the system.
Mm.
When we were working, with Ammonoosuc, and we were trying to get, more veterans from the American Legion, to sign up for Medicare and such. And a lot of them just simply they don't trust the government,
Mm.
And, I've been in the military. I have a total of 34 years, and so 30 of them, well, I should say 4 years was active and the rest was reserves. But learning more about on the reserves and more about people that had spent time in the military, they don't trust the government, they don't trust the system. So, trying to get to them and trying to let them know what programs are available, it's like, oh, that's just bullshit. Just don't bother. So that's what I found as far as working with Ed on our biggest issue with getting the programs, getting the vets to sign up for the programs. And a lot of them feel, I don't need it, type of deal. And I'm so thankful that I stayed in the military, to get the benefits, because especially with Ammonoosuc, they really take care of the vets.
Mm-hmm. And it's one of the challenges I think we have in rural areas, the dispersion of people over a lot of miles. So trying to find whether we're looking to do outreach for veterans or people who have loved ones in assisted or skilled nursing. It's very few people over a lot of miles and trying to find them. And as Bob said, the um, trust is pretty important. And it was not great before this happened. And I think it's going to increase our challenge of doing outreach to veterans to make sure that any of these changes that affect them, that we can help them figure out how to navigate that. And so.
And part of it too, when I was on active duty or even the reserves, nobody ever educated you to say, you should stay in because of the medical benefit you're going to get afterwards. It was never discussed, never encouraged. The attitude was, you need to get out. And that was from, some of the other members. But I'm so thankful that I stayed in because, I got 3 daughters and a wife, and my wife now is covered. The daughters, of course, are out. But, and Ammonoosuc, when I first became on a board member with them, I said, I asked about the medical benefits. What was the program called, Ed?
Oh, TRICARE.
TRICARE. And they said, oh, no, we don't have that. I said, well, maybe we should look into it. And it took 6 months, and Ammonoosuc picked up TRICARE and picked up my whole family.
Yeah.
So
that
it's
was one of the values of having, board directors who are patients and board directors who are veterans is we might not have ever learned that without that feedback. And I think that's the purpose of, part of the purpose of this podcast is to educate the public on what is available, what is being compromised, and their voice needs to be heard. So I appreciate John providing an opportunity so we can educate people on, the importance of things like Medicaid, and they might not realize that it's going to affect them.
Yeah.
Let me ask the question then, because what it sounds from hearing you is that we have a very complex system of health access, healthcare, and life support systems in the North Country, where we have a rapidly aging population, right? A lot of seasonal workers who don't get health care, and a lot of veterans. And so we're seeing some big changes now coming out of DC, right? Yesterday, that vote, now it's in the House. And we're thinking a lot just about Medicaid and the Affordable Care Act, but there's all these consequences you're bringing up in terms of nursing homes, in terms of veteran services, in terms of community services. What are you concerned about? What do we need to know? And how is this going to affect a part of the state that is constantly trying to bring in new people, bring in new investment. That is a beautiful, wonderful place to live, but where local hospitals have struggled mightily over the last decade. We've seen consolidation and services pared back, maternity wards close. What if you had a crystal ball, what are you worried about?
Yeah, when I think about it, um, although I worry about Ammonoosuc in some respects for good reasons, um, I'm fully aware of our critical access hospitals, Spear, Memorial in Plymouth and Cottage, LRH, Weeks, Androscoggin, Upper Connecticut. They're not swimming in money by any means. They're critical access hospitals for a reason, okay? It's in the name. Uh, and since I've been here, the delivery services at Cottage Hospital um, were no longer financially sustainable, and Weeks as well.
Mhm.
Androscoggin is the only hospital in Coos County who delivers babies, and I worry about any impact it might have on them. When people come here, regardless if they want to work for us or work for someone else or a young family, tell me about the schools, tell me about where I deliver my child, and tell me about high-speed internet. So the high-speed internet, I think we're getting that one resolved. But it is challenging to bring younger people into the community to get a nice generational balance. When they do come, they make significant contributions, either working in the healthcare system or some of them are very entrepreneurial. We have Super Secret Ice Cream in Bethlehem. This is a boomerang family that came back. They went away, they came back. So you see them stand up these nice businesses.
Mhm.
So yeah, I worry about the health impact, but the economic impact as well.
Raymond, Bob, anything to add in terms of what you're
Yeah,
thinking?
I mean, even though, I'm not technically in the North Country, the issues aren't totally unique. We have two hospitals in Stratford County. Uh, Frisbee Hospital, even though they had an agreement with the state, stopped delivering babies. And
Pretty quickly.
a friend of mine works at Wentworth Douglas Hospital, which now becomes the only hospital that has a delivery setup. Delivered 180 babies last month, and they're just not, that's very difficult to maintain on a consistent basis. And people in Stratford County, there's something about crossing that bridge that goes to Portsmouth, that a lot of people just don't like to do. And so they like to stay in their county, and it's a challenge for them when you only have one hospital that uh, delivers children. And also, Frisbee is I think, in a challenging financial situation, which is why they merged with, a Massachusetts hospital. And Wentworth Douglas did the same thing. And then you're hearing that Mass General, who kind of took over Wentworth Douglas, is looking at a $500 million deficit over a couple of years. And you're wondering, oh, geez, just when you thought, Wentworth Douglas Hospital was, um, merging with a large Massachusetts hospital, that's going to put them on really great financial footing for years and years to come. And then, all of a sudden, you're hearing about layoffs and cutbacks at your local hospital, at the only local hospital that delivers babies.
Mm.
And so you become concerned about that. All of my residents who need hospitalization primarily go to Wentworth Douglas, and then are transferred out from there if they have some kind of
Mhm.
more complicated medical need. And so you have concerns about those things also.
Yeah. Is a business owner, Bob. I mean, I know it's hard to get people in the trades. I mean, what do you think the impact of access to care? Some of them, may not have insurance. Some of them may be Medicaidable. Some of them may be on our sliding fee scale. What do you see the impact on your ability to get plumbers, electricians, carpenters, and everything else?
Well, I've been in building now for over 40 years. And the last 10 years has really been difficult getting young kids to get into the trades. Um, it started, what, 10, 15, 20 years ago when they said, go to college, go to college. And these kids that spent thousands of dollars going to college and all they got out of college was a bill. They got no degree or really any useful education. So our problem now is they're trying to get into the trades. They're now, so we are shorthanded of talented young kids to come in to carry the load in the construction industry. So we need more talent up here in the construction industry.
And they
We're all
struggle
getting
getting
old. And
they struggle getting in health insurance because,
well,
again, maybe they're a carpenter part of the year, and maybe they're making snow on Cannon Mountain part of the year.
right.
And you look at, if we don't do that, our housing right now is 0.6% rental vacancy. So if I'm trying to hire someone, an RN, a physician, um, certified medical assistant, I'm having a hard time finding housing at any price. So where do I deliver my baby? What do you mean I can't find housing? And if I can't hire these people into the healthcare system that is now being de-invested in, it all starts to connect. You need healthy people to build houses,
Yeah.
and I need staff to keep them healthy, and they have to have houses to live in. So it's a very
Well,
complex system.
and it's starting to break apart. Um, God, 20, 30 years ago, you had minimum 2 acres, for a single family home. Up here where I live in Franconia, we got 5 acres, for a single family home. And we were not allowed to have any additional dwelling units. So the land was only for one family. You can sneak, you had to sneak your mother-in-law in, to get them to live with you. You had to get special dispensation for that. And now they're realizing that we need the manpower, we need the housing. So they've now authorized additional dwelling units, meaning if you have a garage, you can convert it into a dwelling unit on your own land, type of deal. Um, I have my house here is a salt box style, and I'm on the side of a mountain, and my basement, we rent it out. And we rent it out, obviously, to the medical field. Most of our tenants have come from Ammonoosuc. So it kind of works out well. But yeah, housing is a real critical income, salaries. I don't know how these kids live on the salary that they make, type of deal.
Yeah, it's tough.
Yeah.
And when those salaries are supported primarily by Medicaid, in other words, in our case, we're hiring or continue to struggle with hiring people, but our source of revenue to offset their wages comes from a depreciating asset.
Yeah.
And again, it was, we were fortunate. I was part of what we affectionately called the traveling roadshow, uh, where three of us from the various counties across the state went to visit the Senate Finance Committee to convince them to restore that 3% cut that the House made for all Medicaid providers.
Yep.
Fortunately, we were successful at that, and the House acquiesced when it came to a committee of conference. But it was, we certainly weren't able to get we would never even think of asking our employees to take a 3% cut in wages.
No.
They're all looking to, get ahead of the consumer price index, which was
Yep.
close to 3%. And so fortunately, we were able to convince the Senate, and then they were able to convince the House and the committee at conference, or found some extra revenue.
Yeah.
And that worked out.
What you point to, Raymond, is the economic multiplier. So for every
Yeah.
dollar of Medicaid, you're going to take that dollar, you're going to pay someone. The economic multiplier is 3. And when you ask people what the number one revenue stream into New Hampshire is, they often think it's liquor stores, and they're close. It's actually Medicaid. So the number one revenue stream coming in is Medicaid. And we've talked about the 50-50 split on straight Medicaid. With Medicaid expansion, if that changes and the feds decrease the amount, Medicaid expansion goes away. That adversely affects us to the tune of $500,000. And then when I think about primary care, for every dollar we invest in primary care, it's a 13-to-1 return on investment that patients who have diabetes, it's in good control, or hypertension's in good control. They don't need to go to the hospital. They don't need to go to the emergency department because their chronic health condition is well managed. And you look at your EDs are $750 to $1,500 a visit. Hospital day in New Hampshire is $2,000, $11,000 in ICU. Primary care visit is, $150 to $300.
Huge difference.
So it's I own a car, right? So I change the oil in my car because it's less expensive than the engine. We can't change engines in humans oftentimes. We're sorry the damage is done if we don't invest in our friends, family, and neighbors on the preventive side.
And that's very typical in the nursing home industry also. The ability to supplement is the best way I can put it. An active family that wants to keep their loved one at home with choices for independence is about a 3-to-1 savings as compared to the cost of nursing home care. Now, obviously, there comes a point in someone's health situation where they can't be kept at home. It's not safe for them to be home, or they don't have the support because they don't have a family, or they have a disinterested family. I mean, I'm sorry to say that, but that's the reality of it. And that if they are, if that forces them to go into to a nursing home, then obviously it's much more expensive. But I think the fascinating thing about the state budget is there was an increase that the governor's increase for nursing home care was stabilized all the way through. And it was a fairly significant increase. Yet the House decreased or tried to decrease by 3%, but never touched the amount that the governor put in the budget on what we call the 504 line, which is the nursing home line. The problem is the choices for independence is sorely underfunded.
Yeah.
So those people that could possibly stay home with supportive home care, which would still be less expensive than nursing home placement, aren't able to do that because there's not an entity that can afford to provide the care because the reimbursement is so low. And to try and explain that, it's just people just don't seem to understand the concept. And but I will tell you that we cannot afford as a state, with the way in which we're aging, and there's nothing we could do about that, right? I mean, that's simply a statistic. And if we don't come up with some viable alternative, well beyond what exists now to nursing home care, the system is broken. I mean, it's going to just totally fall apart because there's just not enough. There will never be enough nursing home beds. We need to keep people at home.
Yes.
Not only that, people want to stay home.
Yeah, they want to stay there. Yeah.
And I applaud that. I mean, when somebody calls here for a potential admission, the first thing we do is ask them, have they explored home care? Is there a way to make it work, with family, with supportive entities, agencies in the community? Have you explored home care? Some have, some haven't. But if we can keep somebody at home, or even permanently or delay their placement. That's the only way we're going to be able to come close to keeping up with the graying of the population in New Hampshire.
So Ray, I belong to the Home Builders Association here in New Hampshire, which is a national organization, and we have what's called training in aging in place.
Mhm.
So when we build a house, we're building it for 20, 30, 40, 50 years in the future so that the family could age in place. So we're making it wheelchair accessible. We're making, the doors, open wider. We're thinking about, what people are going to need. My house is a salt box, and right now I'm sitting in my future bedroom.
Yep.
Because it's an office now, but it's on the ground floor. And when we need to, and we close up the business, this becomes our master bedroom. We got a bathroom right on the other side. We got a conference room that will be the changing room. So we're pre-planning for staying here in place.
Great.
And I've actually done that in my own house. We
Yep.
moved into a house 5 years ago that's all one level, so
Yep.
that my wife and I can age in place.
Yep.
I don't want
Excellent.
to interrupt, but I know we've got some media on the call. This has been such a great discussion, but my colleague Rachel is going to see if they have any questions for you because they've been kind to listen to what we've had to say and see if they have any reaction, Rachel.
Thank you, Jime, and thank you everybody for joining us today for this really important conversation. For any of our press who has joined us today, if you have any questions for our speakers, please put those in the Q&A box at the bottom of your screen. And if one of your questions is for a specific speaker, you can note that in your question. Our first question was submitted ahead of time by someone who couldn't make it today. And that question's for Raymond. And that is, what are you hearing, or could you explain more about what you're hearing from nursing home residents and their families about the impacts of this bill and how it could impact their ability to stay in their nursing home?
I don't think, fortunately, because we're county supported, we're in a little better situation in terms of having a backdrop. The question is, how far is the county taxpayer going to be willing to go if our main source of revenue, which in this case is Medicaid, decreases instead of increases to support our continued operation? I mean, our county legislators now talk about having the counties not run nursing homes anymore. I mean, that experiment's been partially tried in other counties in the western part of the state, and it turned out to be a failure because the model just doesn't run the same. And in our county, of course, as I mentioned earlier, our model is based on supporting the private and the for-profit nursing homes in our county by helping them manage their Medicaid population that they just can't afford to do. It's not that they don't do a great job. They do a great job. It's just that they can't financially afford to just take Medicaid people because just a quick example. All of the allowable costs for nursing home operation are all collected by the state. And then the state determines how much money they have to pay and then cut the allowable cost based on the amount of money they have to pay. Right now, as of July 1st, day before yesterday, we got our new rates. It's a 28% less than the allowable cost. It's called it's a budget cutting factor. And they just simply say, okay, well, we know this is what you deserve, but guess what? We don't have enough money appropriated, so we're cutting you out 28%. So not only does Medicaid not pay the freight, but when you cut it 28%, it's substantially less. I mean, I don't want to scare any of our families. I don't think we're at that point, but these are certainly points for future consideration.
And it's hard to know, what's going to come down the pike if it's not on the road yet. I want to say thank you. And Rachel, thank you for working with the media on the call, the media who've joined us, Ed, Bob, Raymond. I feel we just scratched the surface and there's lots more to go into. So maybe we can do it all again in a few weeks and see where we are then. But thank you for giving us this perspective. Your rural New Hampshire faces some real challenges, and less funding for healthcare access and healthcare overall, including veteran care, including nursing care, is a pretty scary thing that we're going to have to continue to ask questions and reach out to our elected officials and speak up. So on behalf of Protect Our Care New Hampshire, I want to say thank you. It's been good to talk to you today, and I look forward to having future discussions on this topic. Thanks all.
Thank you.
All right. Thanks. Have a great day.
Thank you now.